Thank you, Chairpersons, and good afternoon, everybody. I am going to speak on essential hemodynamic assessment in CCU by echo. Now, the word hemodynamics means the blood flow, study of the blood flow and its associated forces in the cardiovascular system. Now, the cardiovascular system itself is very complex. It has got 4 chambers. The 4 different chambers, they are connected to various arteries and veins. And to make the things complicated, the pressure in the 4 different chambers are different. Moreover, in the CCU setting, we use a lot of medicines which have direct effect on the cardiovascular system. So, a lot of hemodynamic mathematical calculations are involved in the assessment, which many people are scared of, but these are highly simplified in the echo machines, and we can measure, we can assess these hemodynamic measurements in the CCU within a minute, and doing the echo at the bedside, which helps in making the diagnosis, to take the decision on the line of management, to guide the various interventions in the CCU. Also, we use this information for follow-up of the patient. 2-dimensional echo and M mode both has signs, various signs of hemodynamic derangement, like when there is aortic regurgitation, we get fluttering of mitral valve. Pulmonary hypertension, we get mid-systolic pulmonary valve closure. Dilated IVC indicates increased RA pressure. In cardiac tamponade, we get RARV collapse. But all these signs, 2D and M mode signs, are very non-specific. On the other hand, with the introduction of the Doppler echo, now we have direct and quantitative technique to measure the various parameters in the CCU, like stroke volume, cardiac output, LV filling pressure, pressure gradient at the site of obstruction, and valve area, intracardiac pressures, right heart hemodynamics. So all of which are very, very valuable in CCU for the management of the patient. Now let us start with the stroke volume and the cardiac output, which is an important hemodynamic parameter. We often come across the patient where we need to measure, and the stroke volume is nothing but the blood flow across an orifice, and cardiac output is the amount of the blood pumped out per minute. Now here is a patient who had the PTCA 3 months back, got admitted in the CCU with upper GI bleeding and hypotension, and we look at the echo. This is the 4 chamber. You see the walls are kissing with each other, smallish LV, smallish RV, very small IVC. So there's no doubt that this patient needs fluid replacement. But before replacement, do we want to have some more information other than these 2-dimensional pictures? Yes, of course, we need to know the LVOT-VTI. Hyperdynamic LV, high ejection fraction, doesn't mean the patient will have a high stroke volume. It is the LVOT-VTI, which is the surrogate for stroke volume. So we measure the stroke LVOT-VTI from apical 5 chamber or apical 3 chamber view, keeping the sample volume in the LVOT within 1 centimeter of aortic valve, and normal value is 15 to 20 centimeter, whereas in this case it was very low. So LVOT-VTI also can be used for follow-up of the fluid responsiveness in these patients. Moreover, using this LVOT-VTI and utilizing the LVOT diameter, we can always calculate the stroke volume. Normally it should be more than 60 ml per beat. In this case, it was very low, so immediately fluid replacement was started. Now, so always focus on the stroke volume rather than LV ejection fraction. Now, another hemodynamic parameter which is very useful in the CCU is the LV filling pressure. A lot of discussions have already taken place. This elevated LV filling pressure is the cause of shortness of breath in diastolic heart failure, and it is measured in the echo quickly by measuring the E by E prime. Now, what is this E by E prime? Everyone knows a ratio. It is the ratio of transmitral E velocity to the E prime. So, as for the latest guidelines, if the average ratio is more than 14 or equal to 14, it indicates the raised LV filling pressure. Now, here is a patient, 65 years old, had the CABG 2 months back, now admitted with all the signs symptoms of heart failure, pedal edema, cramps, shortness of breath. We do the echocardiography. We see the LA is enlarged, LV showing some concentric hypertrophy, but good systolic function in the long axis, in the short axis, all the segments are contracting, so also in the 4-chamber view. So what is then why he is having the shortness of breath? There comes the role of assessment of diastolic function. We see that it's a pseudo-normal pattern, and the average E by E prime was 20, which is much more than 14. So he is basically in diastolic heart failure, and the treatment was started accordingly. Another information, hemodynamic information, is the pressure gradient at the site of obstruction, where often we receive the patient in the CCU with severe valvular stenosis, and we measure the pressure gradient by utilizing the modified Bernoulli equation, which says pressure gradient is equal to 4V squared. So here is a patient, 68 years, got admitted in CCU with chest pain, SOB, repeated syncope, on auscultation, systolic murmur, ECG, LVH. So immediately we do the echo, and we see densely calcified aortic valve in the parasternal long axis, and color flow shows the turbulence. So this is a clean-cut case of severe aortic stenosis, but we cannot measure the gradient here, so we go to the 5-chamber or 3-chamber view, and we do the continuous wave Doppler, where we mean gradient is 58. We always look at the mean gradient because it corresponds well with the one measured in the measured by cath in the cath lab, I mean cardiac cath. And as per the latest guidelines, if it is more than or equal to 40 millimeter of mercury, we say it's severe. However, look at this patient, a similar patient with similar clinical background. We see a dense calcification in the aortic valve in the long axis, also in the 5-chamber, and put the color flow, hardly any blood is going there, and we get a mean gradient of 27 millimeter of mercury. So, looking at the valve, we thought it's severe. Why the gradient is so low? So, what it is, actually, if you look at the LV, it's hardly, you see the ejection fraction is so low. So, we are basically dealing with low flow, low gradient aortic stenosis with reduced LV ejection fraction. Here, the severity of the aortic stenosis has to be assessed by continuity equation, measuring the aortic valve area, which the principle of which is whatever goes in must come out. So whatever blood is flowing through the alveoli must come out through the aortic valve. So we know how to measure the alveoli stroke volume. Now we are going to measure the aortic valve stroke volume. That can be done only with another step, that is the measurement of aortic valve VTI by CW in addition to the measurement of the stroke volume across LVOT. So we do that, and we measure the aortic valve VTI by doing CW across the aortic valve flow, and we get the aortic valve area 0.87 square centimeter. And as per the latest guidelines, it is severe since it's less than 1. Now, another situation which often we come across is the pericardial tamponade in the CCU. And here is a patient after removal of the TPI lead, sudden hypotension, large pericardial effusion, diastolic collapse. As you can see, mitral valve is opened here. The RV free wall is collapsing, and not only the RV wall, it is the RA also showing a systolic collapse throughout the systole, and in front of the RV, lot of fluid. IVC is dilated with sluggish respiratory variation, and we always look at the exaggerated respiratory variation in the inflow velocity of mitral valve and tricuspid valve, where we got more than 25% respiratory variation in mitral and more than 40% variation across the tricuspid, which all the findings are suggestive of tamponade. Immediate pericardiocentesis was done. And a lot of information of right heart hemodynamics can be obtained by the echocardiography, like systolic PA pressure from the tear jet, RA pressure from the IVC, and also utilizing the PR jet, we can get diastolic PA pressure by measuring the diastolic PR gradient, adding RA pressure, and peak PR and adding the RA pressure gives the mean pulmonary arterial pressure. And also from the acceleration time, we can measure mean pulmonary arterial pressure. If it is less than 100 millisecond, it indicates pH. Normally, it should be more than 130. And utilizing this acceleration time, we can also measure the mean gradient in different, these are the equations. However, we must remember that there is reduced accuracy when the heart rate is less than 60 or more than 100 beats per minute. So here I end with the take-home message that there is an unquestionable role of hemodynamic assessment in the CCU, so it should be practiced in day-to-day, the examination of the patient in the CCU. Thank you.